Our next speaker is a very well-known infectious disease specialist in Kansas City. I have personally known him since I joined Real Time Laboratories 3 years ago. We have collaborated on many publications. He's also an active member of our scientific committee at Real Time Laboratories, so he's basically a partner in crime with us. He graduated with honors from University of Kansas School of Medicine. He's affiliated with St. Luke's Hospital of Kansas City. During his 42 years of diverse experiences and practice, he has had a long-standing interest in patients with chronic fatigue syndrome and Lyme disease. His recent research on the role of mold and mycotoxins in these chronically ill patients has resulted in collaborations with Real Time Laboratories and led to publications in 3 peer-reviewed journals, including Toxins. The title of his talk today is called Chronic Illness Related to Mold and Mycotoxins, Role of the Sinuses and Treatment Strategies. Please put your hands together and welcome Dr. Joseph Brewer.
Thank you very much. It's a pleasure to be here and talk to you about this interesting subject that many of you have attended some of these symposia before. I don't have any significant disclosures. There are the learning objectives, which are in the slides that you have. I will be addressing some experimental or off-label use of drugs during my talk today. So this is the problem. Neil and I and others believe that water-damaged buildings are certainly the source of most of the toxic mold exposure, basically with water intrusion and growth of mold in the indoor environment. This is just a slide from a paper that shows you the potpourri of molds that can be found in water-damaged buildings. You can see they'll grow on almost anything from gypsum wall board. We do think the dust is important because, as Dr. Nathan said, the spores will often settle in the dust. They're heavier, and so we think the dust component is substantially important. This is not a complete list. This is a partial list of a variety of mold species and the mycotoxins they make. And again, this is only a partial list. But these are some of the more common ones, and particularly in the toxins that they produce, as you can see, are some of the major ones that we can assay for in the testing that is now available. So indoor mold growth is relatively simple. It takes water and a food source. So there's water intrusion, water damage. There's a substrate for mold growth, which is basically virtually any cellulose plant-based material. The mold growth starts and continues as long as there's an adequate moisture source, and then produces a potpourri of items that are secondary metabolites, mycotoxins, the VOCs, volatile organic compounds, etc. We're going to focus today predominantly on the mycotoxins, but it is likely that some of these other things can impact illness as well, particularly allergy, but also chemical sensitivity and so forth. So the question with mycotoxins that originally came up when I got into this about 5 or 6 years ago is, well, can you get sick from mycotoxins? Now, for decades, the public health folks, CDC, allergists, et cetera, have indicated that you can get sick from mold, basically from a respiratory standpoint, allergy, asthma, and so forth. But the question is, could you get sick from these toxic metabolites? So this is an interesting paper. This actually came from CDC's Morbidity and Mortality Weekly Report. And note the date there is July 2006. So this was after Hurricane Katrina in New Orleans. And I've highlighted in red there at the bottom what CDC says down here, and it's whether the concentration of airborne mold toxins are high enough to cause human disease through inhalation is unknown. And they indicate it's not proven, and they've suggested it's unlikely. So, and to my knowledge, they've really not, in the last decade or so since then, they've not really changed their stance on this, that mycotoxins actually may not really be important. We would beg to differ and show you some data, as you've already heard, to address that. So this was our first paper published in Toxins, Detection of Mycotoxins in Patients with Chronic Fatigue Syndrome. And so basically, some of you have seen this before, we ended up with 112 patients that met the CDC case definition for chronic fatigue syndrome that had been the so-called FACUDA definition that had been published back in the early 90s. And we found that if you took any of the 3 mycotoxins that were available on the assay at that time, that 93% had at least one of the mycotoxins. And then Dr. Hooper's group at Real Time Laboratories had done a control group. Previously, this was not a simultaneous control group. This was a prior historical control group, but these were people who were healthy and did not have a history of significant mold exposure, and 0 out of 55 had detectable toxins. Now, this is the breakdown of the specific toxins that we found in these 112 patients. As you can see, some of them would have a single toxin, others had 2 of the toxins, and then a few of them, about 9%, had all 3 toxins. I will say that I think the aflatoxin assay is more sensitive now. I think Dr. Hooper would agree than it was back then, so I think we are picking up more aflatoxin these days than we would have back then. I think that's the reason we had a lower aflatoxin back then. This is just one of my early patients showing the kind of levels. This lady, interestingly enough, had quite high levels of all 3 mycotoxins, but was only moderately ill. She had kind of a chronic fatigue fibromyalgia type illness, but was not one of my sicker or sickest patients. She was moderately ill, but as you can see, she had all 3 toxins present. This is an interesting family. This is family number 1 that's in the paper. This is a gentleman and his wife and 2 children, and I had seen the father for years for chronic fatigue syndrome, fairly severe chronic fatigue syndrome. His wife had milder fibromyalgia and could still work full time. And then they had 2 daughters, and one of the daughters, the younger one, is quite ill, unable to attend school, etc., with chronic fatigue syndrome, also a plethora of allergies and so forth. And then the older daughter was not quite as bad, but they all had illness of varying degrees and similar type illness. And so you can see their mycotoxin levels in the same family. This family eventually found the problem in their home. They'd lived in that house before the 2 daughters were born, and so they had actually grown up being exposed to mold their entire life. And we actually, they did multiple ERMI tests and so forth on the home, and also mycotoxin testing on the home that was sent to Real Time, and we found the same mycotoxins in their home that we found in their urine. I really like this paper. This is a paper from Dr. Strauss's group when before Dr. Strauss retired from Texas Tech. So this is actually a paper looking at detection of trichothecene mycotoxins in the serum, and it looks at and compares it with their exposure to indoor environments. So they divided these patients into 3 groups. So group 1 had documented exposure to Stachybotrys. numerous symptoms, which I'll show you in a second, and then trichothecenes were present in the serum of 77% of these patients. Group 2 had been exposed to mold in the indoor environment, but it was not known whether or not it was Stachybotrys or not. Their symptoms varied, but were generally milder than Group 1, and trichothecenes were present in 36% of their blood. Group 3 had no known mold or mycotoxin exposure. They were basically the healthy control group with no symptoms, and they only found trichothecenes present in 3% of their serum assays. Here are the symptoms that they outlined in the paper. Typical symptoms we see in our mold exposure patients: fatigue, a lot of neurological and cognitive, headaches, nausea, vomiting. Note sinusitis is on there, nosebleeds, allergies, congestion, cough, etc. Now this is an interesting paper that was one of Dr. Thrasher's last publications, maybe not the last, but one of the last before he unfortunately passed away a year and a half or so ago. This is an interesting family with a chronic fatigue syndrome illness after exposure in their home, which turned out to be a water-damaged building. And this is a case report, but it's a case report of these 5 people. So you can see there's the father, the mother, and then they have 3 daughters. And basically they're all healthy other than just colds and so forth before being in the water-damaged home. And then they were in the water-damaged home. You can see a plethora of symptoms there, both respiratory and non-respiratory. Interestingly, on the far right there, over here, the symptoms persisted even though they left the home, and they still had symptoms 3 years later. So, not quite as prominent and not as many symptoms, but they still had a number of symptoms present. This is the analysis of that home. Note that was the master bath there, the 3 million pin asp spores, a lot of mold problems in that home that they were exposed to. This is their mycotoxin testing from both the home and the patients. Note that mycotoxins, particularly trichothecenes, were found under the refrigerator. That was Dr. Thrasher's favorite, was to go under the refrigerator for dust and do mycotoxin testing on the dust. And we have done that in a number of patients and found it very useful. And then you can see the urine testing there. The entire family had evidence of either ochratoxin, trichothecenes, or both. So again, a chronic fatigue syndrome type illness that came on in 5 out of 5 people from being in a heavily water-damaged home with substantial amount of mold. So what we've learned over the last 5 years or so, now into 2018, is that in our experience, greater than 95% of patients with chronic illness, chronic fatigue, fibromyalgia, chronic Lyme, overlapping illnesses, chemical sensitivities, et cetera, do test positive for mycotoxins on the urine assay. At least 90% of those will give a history of at least a prior exposure to a water-damaged building, and some recall the onset of symptoms at the time of mold exposure, whereas others had the onset of symptoms months or years later. Now, the newer addition, so these were all published prior to gliotoxin becoming available. Gliotoxin became available in 2016, so I thought I'd make a few comments on it. It is a secondary metabolite that belongs to that chemical group there that I try not to attempt to pronounce. It was the first compound in this grouping that was found. It's actually called gliotoxin. A lot of people think that has something to do with glia in the brain and so forth. It does not. Gliotoxin is actually derived from the first fungus from which they isolated it, which was Gliocladium. There are a number of toxic compounds in this category, and so gliotoxin is simply one representative. Gliotoxin is predominantly made by Aspergillus species. This is from one of Dr. Thrasher's papers on mycotoxins and where they reviewed the literature. Now, these are actually clinical isolates of invasive aspergillosis. Aspergillus fumigatus was the most common clinical isolate, which has been my experience in immunocompromised patients that we see in the hospital. And as you can see, the clinical isolates in patients who were sick with invasive aspergillosis, 98% had gliotoxin present, and their environments were checked, and 96% of the environments of the Aspergillus fumigatus that came out of their environments produced gliotoxin. Aspergilla niger was fairly high at 56% and flavus at 15%. Again, these are from the clinical isolates. I went back and looked at 10 of our patients. These were from the original paper that had ERMIs done on their homes, and and on the ERMI testing, fumigatus, niger, or flavus was found in 10 out of 10 homes, and in 8 out of the 10, all three were present. So very, very common to find gliotoxin-producing strains in water-damaged homes. This is my first run at gliotoxin testing results in our patients. This was about a 15-month period where we tested about 250 patients. This was after the test became available in early 2016, and 98% of the patients with chronic illness tested positive for gliotoxin on the real-time urine assay. Now, it often comes up not only with the other toxins, but with gliotoxin. What about healthy folks? What about the control population? Well, here's the data we have so far. The gliotoxin, real-time did some testing on hematologic malignancy patients with invasive aspergillosis, and 4 of 6 of those serum specimens, these are serum, had gliotoxin present in their serum. Dr. Hooper shared with me that they did a testing of healthy blood donors from a company called HemaCare. These were, again, serum specimens, and 25 out of 25 were negative for gliotoxin. And then real-time eventually went back and tested those 50 healthy people that were in the original paper, and none of those were positive. One was equivocal for gliotoxin. So it appears gliotoxin is not present in the healthy population. Now, one of the things that comes up with mold and mycotoxins is if these things are bad and if they produce toxicity, how do they do so? And I think it's via an endless array of mechanisms. Certainly we know from extensive literature on mycotoxins that they can bind to DNA and RNA and probably render it non-functional. They can alter protein synthesis and functions, which would include obviously a number of enzyme systems, oxidative stress, with lipid peroxidation being proven, depletes antioxidants, alters cell membrane function and transport. These are potent mitochondrial toxins, as Dr. Nathan has already mentioned, and they can alter apoptosis. Now, some other observations that we have come across in the last few years is, so that the slide that I just showed you would probably be mechanisms of direct toxicity at a metabolic biochemical level. The other issue is that we know these are immune suppressive toxins, so these could lead to activation via their immune suppression. In other words, the mold leads to enough immune suppression that it leads to activation of organisms that are latent in the body. Examples might be the herpes viruses, in particular Epstein-Barr virus, Borrelia in our Lyme patients, etc. Some newer thoughts that I've had on this are actually the reverse of immune suppression, which is immune activation. Now, Dr. Nathan already mentioned mast cell activation syndrome. I've been actually talking to my patients about this, looking for historical elements in their history to suggest mast cell activation, and just as he suggested, I find it a very high percentage of patients that seem to have evidence of mast cell activation. Would be very clear that both mold themselves, the mold spores, the hyphae, et cetera, can trigger mast cell degranulation and so forth, as could the mycotoxins. Another one that I've been intrigued with, most of you probably not heard of this one, is could mycotoxins activate human endogenous retrovirus, or HERVs? Many of you may not know much about HERVs. This is a kind of an intriguing area, which particularly intrigues me in the field of infectious diseases. I've had a long-standing treatment experience with HIV/AIDS patients. So these are endogenous retroviruses. All of us in this room, about 8% of our genome is made up of HERVs. These are ancient retroviruses that were passed down genetically through the sperm and the egg from our parents and all of our prior generations. Most of these are inactive and dormant, inactive DNA, but they can activate, and the thing that often activates them to produce active viral proteins and so forth is cytokines and oxidative stress, which we know that mycotoxins can do. The best HERV data with disease association is with multiple sclerosis, and it is very impressive. If you get a chance to look at it, it's mainly from a group in Italy. It is incredibly impressive, the connection with multiple sclerosis. But again, it could be a domino effect of if the HERV was there dormant and something had to activate it. So Dr. Nathan's kind of already touched on this. When I look at every single mold mycotoxin case, I look at three issues. Current exposure, in other words, are they living in an environment or working in an environment where they're still being exposed? Is their exposure past exposure only and not current? In other words, their current environment appears to be fine, they've had it checked, they've had good testing done on their home, they don't work, so they don't go to a place of employment, and their only exposures in the past. And then we have a number of patients in which it's both. They've had past exposure from a house or work building or whatever, an apartment, and then they still have ongoing current exposure. And as Dr. Nathan pointed out, sometimes those patients are very difficult because of, he said it perfectly, they are stuck. They can't get out of their home because of, as he mentioned, social and financial reasons. Those are tough cases. This is a very interesting paper that was just published. This is a 2018 publication. And this is a office building in Virginia that they've studied, I believe, for about 8 years. So they actually have done multiple assessments on the people who worked in this. Is over 1,000 employees in this. It's like a 20-story office building. And those of you who do mold remediation, I would suggest that you read this paper. It's very intriguing. So this is an old building. It had a lot of problems with water damage and intrusion, and they've remediated it several times. So they had assessments of the the employees who work there and their symptoms before they did the first remediation, and then after the first remediation, and then they continued to have these symptom assessments as they went on through the remediations. And basically what they found is that these patients, or some of them were patients, but these employees who work there, many of them remained symptomatic despite multiple remediations of the building. And that's what I have highlighted there in red at the bottom is they continue to be symptomatic. Now the respiratory symptoms were the ones that generally improved the most. The systemic symptoms, the fatigue, the headaches, the cognitive impairments and so forth were the ones that would tend to linger. Very intriguing paper. Okay, so one of the things that bothered me early on was that I would see a lot of patients that would say, you know, doc, I was exposed a long time ago, but I don't think mold's my problem anymore because I haven't been exposed in a long time, and shouldn't it go away after you leave the building that caused the problem in the first place? And I said, sure, yeah, that ought to be the case. Well, it turns out it's not the case. Many of these people remain ill and actually get, as Dr. Nathan mentioned, they become more sensitive over time and so forth. So this is a case history that I presented before, which was one of the early on patients. She was actually in this first paper. She was exposed to an apartment. This was after she got out of college, about 20 years before the current time, which would have been 2012. Her symptoms did start while she was living in that apartment, and she indicated that there was clearly mold in this little studio apartment she had. She has not lived in that original building since, and she, to her knowledge, has not had an environment of concern for over 15 years. But she's had chronic symptoms since living in the first environment. A random urine specimen done 20 years after living in that building demonstrated elevated levels of mycotoxins. So the question that came up when I started seeing patients like this is, now, wait a minute, what's going on here? How can you have mycotoxins that are still present 20 years later? I mean, even if you're a slow detoxer, I mean, my goodness. And she had quite elevated levels of mycotoxins, and actually had her current home checked, and it was pristine in terms of environmental assessment. So then we came up with the idea, and Dr. Thrasher and Dr. Hooper and I talked about this. Dr. Thrasher was kind of maybe one of the first ones that turned me on to the idea of the sinuses. I'd also read some of Dr. Dennis's work, and the mycotoxin producing fungi or molds may be internal, and they're still producing mycotoxins. But if they are internal, where are they? Well, the one that we have the best evidence for, in my opinion by far, are the nose and paranasal sinuses. So that will kind of launch us into the next part of the talk, which is the data on the sinuses and then what we do about it. And the treatment would be aimed at eliminating the fungi or mold from the sinuses. So this is our, I guess this was our second paper in which we basically asked the question and then address it in the paper: is nasosinus fungal biofilm the culprit for patients who have had prior exposure and have ongoing mycotoxin toxicity? So this is the data that we generated from the paper. So this paper is basically a literature review, and Dr. Dennis, who you'll hear from later, did some of this work. So we basically looked at whether mold is present in the sinuses, are mycotoxin-producing species of mold present in the sinuses. Can you detect mycotoxins in these patients, in their urine, in their nasal washings, et cetera? And the answer is yes to all the above. Now, as you'll see, healthy people we all have mold in our sinuses. It's part of breathing air, but they may not necessarily be mycotoxin-producing mold and fungi, and we may not be sensitive to them. And as you can see here, that they were found, we did multiple studies, found them in the urine and then in nasal washings. Now this is another of a paper that was published by Dr. Thrasher. This was a different family who became ill in a water-damaged home. And as you can see here, the multiple family members had mycotoxins present in the urine and so forth. But look at the nasal secretions. They found mycotoxins. They did nasal washings on these patients, and they found mycotoxins present in the nasal washings as well as the urine. There's a couple of interesting other vignettes which I don't have time to get into in this paper, but it's a fascinating paper. It's kind of a fun read. They found mycotoxins in breast milk of the mother because she, in the later stages of living in this home, she became pregnant with their youngest child, and that child was born with some abnormalities, and they found mycotoxins in the placenta. And then note the dog. They found mycotoxins in the dog, and the dog had all of these lipomas, and the lipomas were positive for mycotoxins, which is kind of curious. Not the point that I was going to make, but it is a curious point in the paper. Now, what about aspergillus and gliotoxin in the sinuses? Again, when we published that first paper, gliotoxin was not available, so I went back and kind of looked at it to see, well, how often is aspergillus and gliotoxin found? Dr. Nathan already showed this in one of his slides, that you can recover aspergillus from the sinuses quite commonly, fumigatus being the most common. So any aspergillus in up to 40% of sinus cultures. Just a picture of the sinuses. The mold, and Dr. Dennis can talk about this much more eloquently than I can, because I am not an ENT doctor. But the mold can colonize any of the sinuses and has been found everywhere in the sinus cavities, including the sphenoids, which are, of course, very difficult to treat. So we asked questions back in that prior paper is, why would we consider the sinuses as a chronic reservoir for mold colonization / infection, more likely colonization, that could produce mycotoxins? Well, fungi are almost always found in the sinuses of the healthy population, are also found in chronic rhinosinusitis cases. Mycotoxin-producing fungi, including the ones that produce gliotoxin, can be found in the sinuses. I might mention, because there's a new chatomium part of the assay now, or chatoglobin, which is the toxin made by chatomium. Chatomium can be found in the sinuses. Mycotoxins can be recovered from nasal washings of patients with mold exposure. The fungi in the sinuses readily form biofilm. There's a huge amount of literature on biofilm formation by fungi as well as bacteria. The mycotoxin-producing fungi in the sinuses are likely embedded in biofilm. That's probably the rule rather than the exception. And direct treatment with antifungals may be helpful. So this is a little cartoon of biofilm. This is bacterial biofilm. As you can see, it starts adhering to a surface, then it begins to evolve, and these are called biofilm colonies. And so in this particular example, the bacteria then become enmeshed in this gooey matrix that protects it from a hostile environment. The next slide is a specific fungal reference to fungal biofilm. So you can see at the top there, the blue arrows are all things that could disrupt the mold. And the mold's down there at the bottom, down here. And all this gooey matrix here is the biofilm. And basically, the biofilm substantially protects the fungus from whatever is trying to attack it from the outside, including antifungal drugs trying to get to it. Now this is an interesting paper that actually looked at gliotoxin production matched with biofilm. And as you can see there, that with biofilm formation, gliotoxin production actually goes up. So that it appears that aspergillus forming biofilm, it actually enhances gliotoxin production. You can almost visualize that occurring in the sinuses. So intranasal therapy, which Dr. Nathan's already touched on, I'll kind of give my 2 cents worth. The concept really has 2 pieces to it. It is likely going to be important to break up the biofilm. And there's a variety of ways to do that. And then antifungal agents. Breaking up the biofilm, probably the most common chemical agent that has been used by us and others is EDTA. It binds cations, and biofilm requires cations to cross-link. Those little cross fibers, they need cations, and so it appears to break up biofilm and prevent new biofilm formation. The other thing that may be important is the contribution of the bacterial component in the environment, in this case being the sinuses. We know that almost all bacteria make biofilm. Now, some probably make more than others. Dr. Nathan mentioned the coagulase negative staphylococci, the ones that Dr. Shoemaker talked about, the Marcons. Staph epidermidis or the coagulase negative staph make a lot of biofilm, but so does Staph aureus, gram-negative rods, et cetera, make biofilm. So dealing with the bacteria may be important, and that was the evolution of some of the BEG sprays and so forth to try to take out the biofilm forming bacteria along with the molds. And then the antifungal agents, Dr. Nathan's kind of already mentioned those, amphotericin B, which is the first one we started with, itraconazole, nystatin, and there are others that I think Dr. Dennis may mention as well. But these are the three that I have mainly used, and we've done quite a bit of work with these. So there have basically been three that we've used that we already noted. Biofilm busters are often useful, in particular EDTA, nasal antibiotics, particularly mupirocin, may be quite helpful. All three antifungals have been shown to work in our experience. A significant number of patients in our experience, or my experience, greater than 75% will improve. Some of them are dramatic. We've had people return to completely normal health with squirting stuff up their nose. Nothing else had ever worked for them, and they completely return to normal health and remain in normal health. Number 7 becomes an issue down below, but the last 2 points. Furthermore, we have in a number of patients, we've actually repeated the urine assay after they've been on, say, 6 to 12 months of therapy with the nasal spray, and we have found the levels go down dramatically in the urine. On top of that, we've had people who have stopped, which is the next to last point there. Relapses when therapy is discontinued are common. My own view of that is the mold grows back. We didn't get it all. We didn't get all the spores out of there, and it grows back. And if it's mycotoxin producing mold, not only does the mold grow back, but it starts producing mycotoxins again, and the urine test goes back up. And we have seen that in a number of patients. Amongst the three, I think we've seen the most nasal side effects with amphotericin B. That is not terribly surprising because Ampho-B has a low pH. It's a very acidic compound. Those of you that might remember back to medical school using it IV, it caused a lot of phlebitis in veins. The reason for that is because it has a low pH. It's very irritating to tissues. Not surprising it's irritating to the nose. Now, if you can get the concentration down low enough where it'll still be effective, as Dr. Nathan mentioned, it probably the side effects can be avoided. We've had less nasal irritative side effects with either itraconazole or nystatin. They all three seem to work. The last point is the sticky one, and that is duration of therapy. All of my patients who've done well on this, and they say, well, I'm getting tired of doing this. Do I have to keep doing this? And the answer is, it's one of those we don't knows, as Dr. Nathan said. We don't know what happens, but we have absolutely seen numerous relapses when the patient stops the therapy. Sometimes it takes a week or two, and I've seen it take up to 18 months before they relapse. The relapse could be re-exposure, but they're living in the same house that tested okay. So with intranasal therapy, there's a number of ways to do it. An antifungal agent, a number of them to pick from. We don't know which one's best. The biofilm busters, antibiotics may be useful, such as mupirocin directed at the biofilm-producing bacteria. The method of administration, there's a number of those as well. A nebulizer, atomizer, and then just squirt pump spray devices like used with the BEG. Now the newest one that I've been trying that Dr. Nathan's already mentioned is silver solution. I have been working with this for about 8 months now, colloidal silver solution. Silver is intriguing for several reasons. It's a very broad spectrum antimicrobial, as you all know. It's been used in medicine for decades topically on the skin surfaces. In vitro analysis demonstrates activity against many bacteria, fungi, and molds. That's been demonstrated now. I did find some papers where silver is actually fungicidal for mold spores, sporicidal, which could be a big issue because if the spores are surviving and that's what's causing the regrowth in the sinuses, then the silver may be helpful for the spores. That's what happens in buildings. The spores remain, and then when there's water intrusion, there they go and regrowth the mold. So ostensibly the same thing can happen in the sinuses. They may be more effective with biofilm busters. We don't know. We don't know. I can't find any studies of how well silver penetrates biofilm. It's a small molecule. You would think it would penetrate well, but biofilm is tricky. It's figured out it's had millions of years of evolution to figure out how to protect the survival of the organism. And I think it is important to attain adequate concentrations because if you don't have a high enough concentration directly topically that's going into the sinuses, then it will probably be lower than the killing effect, the concentration required to kill the mold. I'll make a few comments on systemic antifungals. These are part of my specialty, so I've used these for decades. Obviously, much more in patients with invasive fungal disease and so forth. The first group are the triazoles, which there's basically 4 of them on the market now. Ketoconazole is out there, but is not used much systemically anymore. It is used topically, even in shampoos and so forth. But the ones used systemically are listed there. They're available both oral and IV. They're tolerated reasonably well, but there are significant adverse effects. These are not easy drugs to use. And they're very successful. Many people with invasive aspergillus in their lungs, disseminated aspergillosis, et cetera, their lives have been saved by taking these drugs. The second group are called the echinocandins. These are IV only. There's 2 main ones on the market right now, mycofungin and caspofungin. I've used them both. Generally well tolerated, and again, much literature on documented success in clinical infections. So do these have a role in the mycotoxin patients? Maybe. I've used them, as has Dr. Nathan. I probably used them more than he has. I've even used the IV ones. I've treated a few patients with IV mycofungin. I've had 2 or 3 patients get completely well in 3 weeks on IV mycofungin. They go from 10 years or 15 years of illness to 100% normal health in 3 weeks on IV mycofungin. I've had people in which IV mycofungin didn't work at all. It did nothing. They didn't feel any better. What's the difference? We don't know. So there's a lot to be learned here. But again, these drugs they're very expensive. Insurance is an issue, and they can have side effects. So obviously, I'm comfortable using them because I've used them my entire career for other things, including invasive fungal infections. But I thought I'd mention them. They may have a role in selected patients. So this is kind of what I call the timeline of mycotoxin illness, sort of based on this whole nasosinus colonization model. So think about the individual that was exposed 20 years earlier. So that there's initial exposure to mycotoxin-producing mold. The symptoms may develop at that time, but they may not develop at that time. They may be delayed. There's then colonization internally in the body. My bet is on the sinuses is the major place. I'm not saying they can't be in the lungs, can't be in the GI tract, et cetera. They may be. But the data is extremely impressive for the sinuses, and this is data from all over the world. And then the chronic mycotoxins from the internal production will lead to an ongoing positive urine assay for years or decades. And if there's ongoing external exposure that's still present, that, as Dr. Nathan already pointed out, that's a major problem, because if they're still living in it, we have to deal with that the best we can. And I agree with him totally. The solution for everybody is not, oh, just move. They can't. Many of them can't move. They're stuck. They financially simply have to stay where they are. I feel sorry for them, but so we have to deal with it the best we can, maybe partial remediations and that sort of thing. But that certainly may accentuate or lead to ongoing symptoms. So in conclusion, it is my opinion, and certainly based on not only our own work, but a pretty extensive review of the literature, that mycotoxins are commonly found in chronic illness patients. That's why I like that paper that showed the 1,000 workers in the office building that after studying them for 8 years and multiple remediation attempts, these people were still sick from working in that office building. Chronic patients with mycotoxins frequently report current or ongoing environmental exposures, past or both. In the past exposure patient, we think the sinuses are the most likely source of ongoing colonization toxin production. Intranasal therapy is likely quite helpful. There's a lot of options there, which we've already mentioned. Colloidal silver may be a new addition to our armamentarium for the nasal sinus colonization. And systemic antifungal therapy might have a role in selected patients. I still use it in a few isolated cases. And that's it.